I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the April 2017 edition of the PRS Journal Club podcast. I'm Chad Purnell, PRS Resident Ambassador from Northwestern, and I'm joined by my co-ambassadors Jordan Frey from NYU and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Hani Sbitany, Assistant Professor of Plastic Surgery at UC San Francisco. Thank you very much, Dr. Sbitany, for joining us for this PRS Journal Club podcast.
Thank you. Glad to be here and looking forward to it.
The article we'll now be discussing is Oncoplastic Breast Reduction Technique and Outcomes in Evolution Over 20 Years by Drs. Loskin, Hart, Brooker, Stiblow, and Carlson from Emory University. As a quick reminder, all the articles that we will discuss today can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So, oncoplastic techniques for breast reduction at the time of lumpectomy are becoming more and more popular, and these authors have always been on the forefront of these techniques, and this is their long-term follow-up paper. So what they wanted to do is they wanted to present a large series of oncoplastic patients with long-term follow-up. And so how they went about this is a 20-year series, essentially from 1994 to 2015, of all patients who underwent partial mastectomy with immediate oncoplastic reduction. So it was a prospectively maintained database. So all of these patients, after their surgery, they were followed up with a screening mammogram every 6 months for 2 years, and then they were followed up annually with mammograms after that. And they recorded a lot of different data, but they recorded just as a part of the few things: margin status, complications, the requirement for additional surgery. Also, in later patients, they used the breast Q for patient-recorded satisfaction pre-op and 1 year or more post-op. What they found whenever they looked at this 20-year series is they had overall 353 patients. Their mean age was 54 and with a mean BMI of 33.7, and these are mostly patients with stage 1 disease. The mean specimen for their reduction was 586 grams, and their overall positive margin rate was 6.2%, with a completion mastectomy rate of 9.9%. The recurrence rate was 2.8%, the reoperation rate was 4.2%, and their revisions for symmetry rates were 4%. Whenever they looked at all of these data, then they did a univariate analysis. And so what the univariate analysis showed was that a specimen over 1,000 grams was associated with positive margins and completion mastectomies. And then also they noticed that a larger tumor was also associated with positive margins. So then they performed a multivariate analysis, and what that showed was that a tumor size greater than 2 centimeters or a specimen size greater than 1,000 grams was also associated with positive margins and a completion mastectomy. And then finally also a completion mastectomy was also associated with lower BMI. They had about a 16.4% rate of complications, and they noted that patients with a BMI over 30 had higher wound healing issues in just the univariate analysis. In the multivariate analysis, there were no associations noted amongst complications and other risk factors. Whenever they looked at the breast Q postoperatively, basically all factors on the breast Q improved significantly postoperatively, specifically improvement in body acceptance and emotional health. And so in the discussion, they talk about some of the barriers to more rapid adoption of oncoplastic techniques, especially systems-based issues here in the United States. And they also highlight that positive margins have been a concern whenever performing these types of reconstructions. And so based on their data, which is a pretty large series, they suggested that perhaps patients that have 1,000-gram reduction, these patients should, rather than being offered an oncoplastic reduction, should be offered a mastectomy instead. They also stressed the importance of radiation and discussed that the tumor bed should always be clipped in order to target radiation, especially because there's significant rearrangement of tissues with oncoplastic techniques. And finally, they highlight the favorable outcomes and the high satisfaction rates associated with oncoplastic reduction, and they feel that it's going to continue to gain popularity as more large series such as theirs are published. I really liked this article. I think that oncoplastic techniques at my institution are definitely on the rise, and I think a lot of surgeons are interested in these types of techniques. But I think it's important to have large series like this to understand the relative indications and contraindications to doing these types of reconstructions. The authors in this paper recommended that patients with over 1,000-gram resection should only be offered a mastectomy. Dr. Sbitany, I wanted to know, what did you think of this article, first of all, and then also, what are your contraindications and relative indications for oncoplastic technique, and do you agree with the authors that 1,000-gram reductions shouldn't be offered?
So first of all, I thought this was an extremely well-written article, and I really enjoyed reading it, mainly because I agree with you when you say that this technique is very powerful for our breast cancer patients, and it's one that we probably should be looking nationally to be performing more often than we are. It's a technique that I can tell you that we employ routinely at UCSF, where I practice, because it really does have a lot of benefit for the right patient. In general, we try to use this technique whenever we anticipate a partial mastectomy of a large size, but more importantly, not just of a large size, but in an extremely large breasted patient. These are the patients that we know have a higher complication rate with a mastectomy, especially when you add in post-mastectomy radiation therapy. And so the ability to offer breast conservation without the need for potentially prosthetic reconstruction in the setting of radiation really makes this technique beneficial. So I understand what the authors are saying here about larger resection weights leading to a higher rate of completion mastectomy, and thus potentially thinking twice in these patients. It's a difficult situation because oftentimes the patients that require larger resections are the larger breasted patients who really benefit from this technique. So I think in general, it's more important not just to look at the resection weight, but the relative percentage of the overall breast volume that that resection weight represents. So when the resection weight of over 1,000 grams is potentially getting to the point where it's more than 30% or so on average of the overall breast volume, then I agree with them that a mastectomy should probably be considered. But as long as it's less than a third of the overall breast volume, I think that there still gives us an area to be more aggressive, or our oncologic surgeons to be more aggressive and take even more tissue, and I think potentially be able to cut down on the mastectomy rate of those patients. So it's a tough situation because this is an extremely beneficial technique for those patients. The second thing I would encourage patients with such a large anticipated resection rate to be put through would be a preoperative MRI. And I think if all of that resection is thought to be based on preoperative MRI in one specific area of the breast, then I think it's probably safer to proceed with the oncoplastic reduction. If they've got multifocal tumors in multiple areas of the breast, then again, potentially those are better patients for a mastectomy.
I think that's a great suggestion, that it's not just a absolute resection weight, it's more of a percentage of the total breast volume. That makes a lot of sense. Jordan, what did you think of this article?
Yeah, I agree. I thought this was a really interesting article and good to read about, something like we've kind of all said we're seeing more and more of, and this is kind of a good guide and review for everyone that's doing more of that, and especially like Dr. Sbitany was saying, in patients who are kind of at high risk for complications after a mastectomy, or in whom it's going to be hard to really have a good aesthetic reconstruction, this can be a really powerful tool. One thing I was curious about, Dr. Sbitany, the authors sort of brush on how they address this, but especially in these patients who are going to get radiation afterwards, how do you address that at the time of surgery in terms of the anticipated changes, so you're ultimately ending up with symmetric breasts?
Yeah, it's a great point. So we always try to anticipate when radiation is necessary, and there's in general two things I try to do to tailor my technique when I'm planning out and marking an oncoplastic reduction, again, when I know that post-mastectomy radiation is going to be involved. Number one is kind of planning out the size that I leave the breast. I know what after a patient heals from a reduction and undergoes radiation therapy that they're on average going to lose up to about 15 to 20% in some cases of the breast volume. So if anything, I try to plan out a reduction that on the affected side, I'm leaving a little bit larger, on average, again, about 15 to 20% in anticipation that they will undergo that amount of volume contraction during radiation. And number two, I try to account for the fact that the radiation is going to put the patient at higher risk of delayed wound healing and similar complications. And so what I try to do is be a little more conservative about my skin markings in this population than I am in standard or non-radiated breast reductions. I try to leave more skin, and I try to make sure that the skin envelope is nice and relaxed and well perfused over the remaining breast tissue, so it's not under tension. and the skin closure is nice and soft and less likely to undergo any incisional dehiscence or delayed wound healing through radiation, and also before radiation, because any delayed healing will just unnecessarily delay radiation treatment in these patients.
Shuja, what was your opinion of this paper?
I agree with what everybody said so far. I think it's a great article that looked at a good number of patients over a long period of time. I agree with Dr. Sbitany that it's a very powerful technique for the larger breasted patient or somebody who might have higher complications with a total mastectomy and a prosthetic reconstruction. And again, with everybody else's experience, I think that we've also seen an increase because of our patient population here. We've seen an increase in these procedures that we've done. They're always a little bit of a more thought-provoking procedure in how you really reconstruct the breast that's been partially resected. And I think it's interesting how we've used our cosmetic techniques to make our reconstruction techniques better. And then there's just one article I wanted to mention that I had read a while ago called A Management Algorithm and Practical Oncoplastic Surgical Techniques for Repairing Partial Mastectomy Defects, which is an MD Anderson article from PRS in 2008 that I thought was a good article when I was first trying to understand this technique and how we approach it. I thought that that was a good article to go over for some of the more junior residents. So for Dr. Sbitany, just to kind of bounce back to what you were talking about in changing your skin markings for an oncoplastic reduction, is there something specific that you change in your actual marking, or does it basically just depend on the patient?
So it really depends on the patient, but in general, the vertical limbs of, when I'm using a wise pattern breast reduction technique for these patients, which is most common because they tend to be larger breasted with larger skin envelopes, I try to be a little more conservative in my markings than I am otherwise. And I try to leave the vertical limbs of the wise pattern a little bit longer, and I tried to leave them at a more acute angle or smaller angle to each other. And if anything, that just preserves a little more skin, especially as you come down towards the T-point of the wise pattern closure. And when we leave more skin and that skin's not under tension, we're less likely to experience a wound breakdown or a wound dehiscence at the T-point, which we all know is the danger zone for wound breakdown in the wise pattern reduction, and it's where it most commonly occurs. So I just try to minimize tension at that T-point as much as possible. Oftentimes it may come at a little bit of a detriment to the final aesthetic outcome because it's going to leave a little bit of extra skin there, but the flip side to that is that most of those patients, again, are undergoing radiation, and if anything, that will contract the skin and retighten a little bit of that extra skin. And so that's really the only specific thing I do with regards to the skin marking to minimize my risk of a complication.
And then my other question is, when we talk about partial breast reconstruction, it's easy to understand the approach to those patients in kind of the extremes of breast size, where patients with smaller breast size may be better off with a mastectomy than trying to undergo a partial breast reconstruction, and then the larger breasted patients that can go through what these authors talk about and what we've been talking about, which is some kind of oncoplastic reduction. Do you have a general approach to partial breast reconstruction in kind of the moderate breasted patient where you can't really take too much tissue, but they don't necessarily need a full mastectomy? Do you have a general approach to that, or again, does it kind of depend on the patient?
So for these moderate breast size patients, the patient in kind of the C cup range where they really could go either way, mastectomy or oncoplastic reduction with a partial mastectomy, I again urge them in consultation with their surgical oncologist and with me to really consider and assess what relative volume of breast tissue is going to be removed. And that's really the key here. So if they're going to undergo a small excision that represents maybe 10 to 20% of their overall breast volume, and in addition to that, we're anticipating post-procedural radiation, then I really encourage them to consider a partial mastectomy because we're removing a relatively small amount of their breast. And so with these techniques, we can really minimize the aesthetic detriment of that procedure. And then again, through radiation with this technique, they're able to avoid the need for a whole breast reconstruction, which we know is at higher risk of a complication in the setting of radiation. And I guide them based on what the anticipated relative percentage of the breast that will be removed. For those patients that are going to be undergoing a resection of over 20 to 30% of their breast volume and higher, well, then I would say that those patients are probably better candidates for mastectomy and whole breast reconstruction, because in those patients, even with our best techniques for oncoplastic surgery, it's harder to replace those relatively higher percentages of breast volume and overcome the aesthetic deformity that's associated with them.
So, Dr. Sbitany, it's Chad again. Just one more question for you before we wrap up discussion on this article. In this paper, the authors were doing all immediate oncoplastic reconstructions. What do you think about the concept of delayed oncoplastic surgery versus immediate? What do you do at your institution, and how do you feel about both of those approaches?
I think whether you do this in the immediate or the delayed setting, they're both valid techniques. I can tell you that here at UCSF, we perform all these procedures when possible in the immediate setting. The main reasons we do that is, number one, of course, it cuts down on the number of necessary surgical procedures that a patient has to undergo. And number two, in the majority of cases, by doing it immediately, we can avoid having to operate on a radiated breast because we're doing all of our surgery up front prior to radiation. And by doing that, it allows us to avoid the higher complication rate that comes if we were to operate later on following radiation. We know that the breast is going to heal better if we perform these procedures prior to radiation. So that's my preferred technique, is to do oncoplastic breast reduction in the immediate setting, for the main reason, again, that it allows us to complete everything, all the operations prior to radiation therapy. But in the end, I think depending on kind of what's available to the patient and what their access is to these procedures, I think when it has to be performed in the delayed setting, it's still of significant aesthetic benefit to patients and should still be considered.
I think with that, we'll end our discussion of this article. Remember to tune in to the other two articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcast that will be broadcasted every month. Also, don't forget to participate in our monthly Twitter, #PRS Journal Club, where we'll be able to interact directly with this month's selected articles' authors. And thank you again, Dr. Sbitany, for joining us.
Thank you. It's my pleasure.